Hi, everyone. I'd like to thank SAGES for this opportunity to present. As she said, I'm Phillip Yang. I'm a medical student at the University of Michigan Medical School. I had the opportunity to work with Dr. Oliver Varban and our team here to look at the risk of narcotic overdose in patients undergoing bariatric surgery. This is my disclosure slides. I did receive funding from the NIH short-term training grant for medical students for this work. We know that obesity is associated with rate-related chronic pain conditions, which increases the risk for prescription opioid use. The most commonly cited reasons for opioid use are joint pain, back pain, injury, and muscle and nerve pain. Specifically from previous studies, we found that, we found in the literature search that patients with a BMI of 40 to 50 have an increased rate of odds of incident long-term prescription opioid use. Specifically, a BMI of 40 to 50 is increased at 158%. And this also increases the risk of opioid-related overdose. So in our project, we looked at the Narcotic score, which is a 3-digit score generated from the Prescription Drug Monitoring Program. It's a set of 3-digit scores from 000 to 999 for narcotics, sedatives, stimulants, and overdose. And in our project, we refer to the Narcotic overdose score as the NARC score. Previous studies have shown that a NARC score of 200 equates to a 10-fold increased risk of narcotic overdose. So this Narcotic score is a patented algorithm that is a weighted combination of many variables listed here. So drug equivalents, number of providers, potentiating drugs, number of pharmacies, and number of overlapping prescription days. In the state of Michigan, where we're from, all providers are required to review the report with all the Narcotic scores before providing opioids. However, the clinical utility of these NARC scores for patients undergoing bariatric surgery is unknown. So the objective of our project is twofold. So one, to evaluate the distribution of these NARC scores among patients undergoing bariatric surgery, and two, to evaluate whether higher NARC scores were associated with specific patient factors, opioid prescribing patterns, or outcomes. So we looked at bariatric surgery patients at a single center academic center. We looked at all patients from 2018 to 2020 who had a preoperative NARC score recorded in the patient chart. This came out to be a total of 306 patients. We then stratified these patients into terciles, with the lower tercile being patients having a NARC score of 0, the middle tercile being patients with a NARC score of 1 to 199, and the upper tercile with patients having a NARC score of 200 to 999. After stratification, we compared patient characteristics, comorbidities, and 30-day risk-adjusted outcomes between patients in the upper and lower terciles. So overall, median NARC scores for all patients was 120. Patients in the lower tercile had a median NARC score of 0, and patients in the upper tercile had a median NARC score of 280. The graph here on the left shows the distribution of NARC scores for all patients, and the dashed lines show how the terciles were distinguished. Patient demographics are as follows. The mean age and preoperative BMI were similar between patients in the upper and lower terciles. We found that patients in the lower tercile were more likely to be male and college educated. And then of note, the majority of patients in both groups had the sleeve gastrectomy procedure. For a lot of the comorbidities that we looked at, including diabetes, hypertension, hyperlipidemia, sleep apnea, and mobility disorder, we found no significant difference in patients between patients in the upper and lower terciles. However, we did find that patients in the upper tercile of NARC scores had significantly higher rates of having been diagnosed with psychiatric disorders. So overall, these rates were up in the 70s, with depression and anxiety being the two major diagnoses. This table here shows the opioid prescriptions at discharge. So the median morphine milligram equivalents at discharge were 75 in both the upper and lower terciles. However, the range varied drastically. So patients in the upper tercile had a range MME at discharge from 0 to 1,500, and patients in the lower had a range of 0 to 225. About 85% of patients in both groups had opioids at discharge. So although patients in the upper and lower terciles had similar rates of adverse events, we did find that patients in the upper tercile had higher rates of preventable ER visits. So this is defined as ER visits where the patient presented but didn't have a complication or require a readmission. So in summary, we found that in our study of bariatric surgery patients, about a third of patients had a NARC score of 200 or greater, which correlates to a 10-fold increased risk of narcotic overdose. Patients in the upper tercile also had higher rates of psychiatric disorders and were more likely to prevent to the ED without a complication or require readmission. So we believe that NARC scores can identify at-risk patients and help tailor additional preoperative counseling and follow-up and reduce unnecessary ER visits and overprescribing of opioids. Thank you.